Good evening, and thank you for tuning in today. On behalf of the University of California, San Francisco Alumni Relations Department, welcome to this evening's program. Tonight's topic is understanding the nursing shortage. We invite you to submit questions by using the Q&A function at the bottom of your Zoom screen. We'll save time towards the end of the program to answer as many questions as time allows. Our discussion moderator tonight is Dr. Joanne Spetz. Dr. Spetz is the director and Brenda and Jeffrey L. Kong Presidential Chair in Healthcare Finance at the Philip R. Lee Institute for Health Policy Studies at UCSF. Her research focuses on the economics of the healthcare workforce, and she has been studying the nursing workforce for nearly 30 years. She has conducted surveys of registered nurses in California since 2005, which shaped state education policies that ended the nursing shortage of the early 2000s. I will now turn it over to our host, Dr. Joanne Spetz.
Good evening. I am very pleased to have a wonderful group of panelists from our School of Nursing with me today, and I will introduce them before we get into some question and answer time for our panel discussion. I have a set of questions about things that I want to learn from their experiences. And then we also have a question and answer button in the Zoom chat, in the Zoom section in your menu. And please put your questions and answers there, and we will go through those as we move along. So I'd like to begin by introducing Professor Carol Dawson-Rose. Professor Rose is the chair and a professor in the Department of Community Health Systems in the School of Nursing. Dr. Dawson-Rose is an alumnus of UCSF School of Nursing and a nurse scientist with over 30 years of combined clinical and research experience. Her scholarly focus is on understanding the experiences of vulnerable populations and using this experience to translate and implement evidence-based interventions for clinical settings with a special expertise in trauma-informed care, substance use, and supporting clinicians. Her work in the US has been translated to global settings, and I have to say that the department of which she is chair was my initial home department at UCSF, so I have a very deep fondness for the rich work that is conducted by Dr. Dawson-Rose and all of her colleagues within the department that she leads. Patton is the Chief Nurse Executive and Chief Nursing Officer for Adult Services, as well as the Vice President for Patient Care Services at UCSF Health. Prior, Pat was the Chief Nursing Officer at the University of California Irvine Health, where he led that organization to their 4th magnet designation. He is active in the American Organization for Nurse Leaders, Association for California Nurse Leaders, and is a current board member through February 2022, as well as the American Nurses Association. In May of 2020, Pat was named as Becker's 50 Hospital and Health System Chief Nursing Officers to Know. And we are very excited that we were able to recruit him up here to San Francisco. Irvine's loss is our gain. And then finally, I'll introduce Assistant Professor Natalie Wilson, who is in the Department of Community Health Systems as well in the UCSF School of Nursing. Dr. Wilson's research is informed by over 26 years of clinical expertise in primary care, HIV, and sexual health. As part of the Ending the HIV Epidemic National Strategy, she is focused on developing innovative solutions to address health inequities and access to HIV prevention and treatment for marginalized populations and those from disadvantaged socioeconomic environments. As a clinician scientist, she uses mixed methods and implementation science to transform healthcare by building in health equity at the individual, system, and community levels. So as you can see, we have a stellar group of people here today to talk about issues in the nursing workforce that we're seeing in the midst of the COVID pandemic. So I'd like to begin with a question for Pat. Since we have the pleasure of having UCSF Health's Chief Nursing Officer on board, I think I just need to ask you, there have been reports of the nursing shortage for a while. Well before the COVID pandemic began, there were concerns about shortages, especially of nurses with very specific and expertise in specific kinds of departments and fields. So before 2020, how were nurses in the health system supporting nurses? And how are they tackling or failing to deal with the nursing shortage that even existed before the pandemic?
Joanne, it's a great question. Before 2020 and before the pandemic began, we looked at specific areas, to your point, around OR nursing, obstetrical nursing, and other specialty areas like cardiac care. For example, post a heart transplant, post lung transplant care, that we were taking care of these patients in those spaces. Those were really hard to find nurses. GI nurses were hard to find to do that in those spaces. Other than that, other areas where it wasn't easy to find, but we did have applications over and over. We were very lucky in the UC system to get those. And I know that others had struggled a little bit, but mainly in those high specialty areas, we were having issues to do that. So when we looked at this holistically, we said, what can we do to look at it differently? How can we support people? How can we look at areas to then bring in those people from those organizations or from those areas of expertise to include new grads to help us really bolster the workforce in those areas? There are some organizations that partnered with schools of nursing that offered a Periop 101 course that allowed them to train nurses in order for them to get them up to speed to go into the OR. There are places like OB that increased their numbers of new grads that they took, because historically maybe they didn't take new graduates into those areas, to help them to do that, to help increase their numbers in that space. And then other areas, for example, the cardiac critical care areas that I mentioned that we had, it was a struggle to figure out, because they're so specialized and so unique, in order to get those places. How do we do that? And again, just decided that we had to invest in our own and take nurses who were either experienced nurses in other areas of nursing to support each other and bring them in and train them to be those nurses, or bring new grads into those spaces. So it was a combination of both in those spaces that we were able to do. Has it been easy? No. Has it been successful? In certain places, absolutely, it has been successful to help us do that. We have had more and more people retiring, so we've got to bolster the nursing workforce with our new graduate nurses as we go forward.
Yeah, a lot of what you're describing about shortages in the specialty areas are things that we've seen statewide in surveys that we have been doing for the Board of Registered Nursing and also independently. So very similar story. Now, how has the COVID pandemic changed things, or has it changed things, or made things worse, or maybe had some silver linings?
It has made things worse, but let me tell you that there is a gleam of hope out there because of the pandemic. So let me tell you how it's made it worse, and then I'm going to tell you about that hopeful factor that we have seen just here at UCSF. And I encourage our listeners to take it back either to their healthcare organizations or to encourage others to do this. So because of the pandemic, we have seen more nurses retire earlier than maybe they would have before. So we've seen an increase in our retention rate because of that. I mean, a decrease of our turnover rate because of that turnover. We've also seen people who have left the profession altogether, not even retire, but go to other professions because of COVID, because they didn't want to deal with that stress and anxiety in that space. But let me give a little gleam of hope of what we've seen because of the pandemic that I found so encouraging at UCSF, and I, again, encourage others to do it. We put out a specific call for nurses who have been out of the profession for over a year in one unit that we had at UCSF. And we said, look, if you'll come back, we will train you. We will provide a training program that will get you oriented and acclimated back into nursing, back into bedside care, if you're willing to come to do that. We did that, and we had over 20 positions we posted, Joanne. And in those 20 positions we posted, we had 90 nurses who had been out of the profession longer than a year apply for those 20 positions. So that gleam of hope is there, that even though the pandemic is upon us, we see that nurses want to come back and be beside their fellow nurses to help them through this pandemic, number one. But number two, that they want to come back and give back because they see this as such a healthcare crisis that they want to provide the help that they were called to the profession to begin with in order to provide that help for our patients who are in need.
That is nice to have that glimmer of hope in the midst of what's been a very, very challenging 18 months. Now, Carol, I know that your research and your leadership in the program that you direct, the overall nurse practitioner education and master's degree programs that are in your department keep you very connected with nurses as well as clinical educators. So what's your sense of what might be changing from the nurses' experience with the pandemic? And how might it be exacerbating or affecting nurses' positions and experiences and ability to feel excited about the work they do every day?
I mean, I think, thank you, Joanne, and thank you and welcome to everybody who's here. One of the things that I think about in terms of this whole, COVID experience that we've all had, and now we've been living it for, not forever, it feels like forever some days. But one of the things that I think that initially happened is the visibility of seeing what nurses do was increased, and people could see what we do. And we were very visible in this way that I think, added to how we feel about our work. And it's just, the sheer stress and the sheer numbers over time, have changed that, right? And nurses' visibility has, I think, diminished a bit, and we're exhausted, right? And I think that, there's a stress on the system and the need for nurses, as Pat was talking about. I mean, that's been there for a while, and we've seen this since the nursing, when we go through these cycles of shortages of nurses, is there that people delay education, right? Their employers aren't as lenient with them, let's say, to take time away from work for education. So those are some of the things that we've seen during this time. So it's harder to get away from work in order to go and return to education and do any kinds of nursing education or advanced degree.
Right, right. And Natalie, I know your research really has a deep focus on vulnerable populations. And so what are you seeing among patients, and then also for the nurses that are working specifically with the most vulnerable patients, which is many of our own faculty and clinicians?
Yeah, so for most of the vulnerable populations, they were out in the open. They were working. They were considered essential personnel to get people to and from work, or they lost employment, or they lost housing because they could not work, say if they were in a restaurant. And it really impacted people getting to, and especially in the beginning, getting to offices, or to the doctor's office to even be seen, because some of those practices actually closed down for a little bit to figure out the pandemic. And then when you think about, getting COVID, there was limited access. So you had the hospitals, and the hospitals were filling up quick. You had the homeless, and we did have Operation Comfort, which were some of the hotels were, and Operation Safer Ground. Those were reserved for the homeless to either quarantine or be safe in a safe environment and isolate, or to heal from COVID. So we had that for patients. And we started innovating our strategies, like doing home HIV testing, specifically for the field that I work in. But it took a minute for us to kind of evolve and catch up. Working in the African American population, we have a high rate of high diagnosis rates of hypertension and diabetes and obesity. lack of access to fresh fruits and vegetables. And so when we're out there and we get sick, we don't have the ability to manage, our care, and we were put at higher risk for this moderate to severe outcomes. And actually, I had one patient who it was a couple with a daughter, and they were in a 1-bedroom. And so the mother had moved into the car when she got COVID, to protect the husband and the daughter. Now, where it comes to nurses, and I think this relates to just some of the shortages, it's kind of hard when you're going to work and you're fighting this battle, and people do see what you do, yet they will go to a concert, or yet they will hold a birthday party. And people were seeing this, and I think nurses saw this and said, do you not care about us? Do you not see us out here? And so those nurses and doctors, as well, physicians who got COVID, they were in the hospital trying to heal, being treated by their coworkers, but also seeing people continuing to not adhere to some of the guidelines that would have protected them.
Yeah, and some of what you're describing about patients, especially vulnerable patients, really ring home, and that there's been a lot of press about the shift to telehealth. And for many people, the shift to telehealth has been great. But it's my understanding that there's a lot of people who desperately need good health care for whom telehealth is not a solution. What's been your experience with that?
So, yeah, I actually moved to telehealth. And it does work for some people. And we also made arrangements. We had a person who would deliver an iPad to a patient so that they could have a visit. But you're correct. Like, there are people that would not work. So, you have to go out to those people. And that's one of the innovative strategies that I'm looking to develop, is really taking healthcare out to the community. For some communities that need quality healthcare so that they can thrive in their communities.
Yeah, that is great work. So Pat, what are some of the insights from the UCSF response to these situations and these challenges of, kind of the logistics as well as the maintaining morale when you are in the midst of a pandemic like this?
It's such a great question, and such a challenge in of itself to make sure you're meeting the needs of all of our staff, right? Not just our nurses, but our physicians, our respiratory therapists, our radiology techs, EVS workers, et cetera, and how we look at that. I think we have done a decent job at logistics around making sure that we have the supplies and equipment that our staff need. We have made sure that we have enough N95 masks. We have made sure we've had enough gowns. We've made sure we've had enough ventilators. We've made sure we had enough ICU beds for our patient. We have been very lucky in the San Francisco Bay Area that we have not been hit as hard as Southern California, as New York City, as Texas, as other places throughout the country that have been hit very, very hard by this pandemic and have been very, very blessed by that. Now, in saying that, that doesn't make us feel any better, because we're still in the trenches of dealing with that work. And at the height at UCSF, we had 90 patients at one time in dealing with the COVID pandemic. And in doing that, it doesn't feel good when you have that many people you're taking care of, and you're having to decrease the number of nurses that you're having to take care of those patients because they are so high needs, right? In our ICUs alone, in developing the proning protocol, sometimes it would take up to 6 people just to turn those patients in order to prone them to that space. That's a lot of manpower it takes to do that. So to your second part of that question, how do you maintain morale? We as leaders have to continue to round. We have to continue to be present. We have to continue to ask, what else do you need? We have to continue to say, what can I do for you to make things better? We have to continue to make sure that we're doing everything in our power to provide more travelers to the situation so that people can take a break, right? So that people can make sure that they can get a week off to go and just relax and to just unplug, to say, I've got to have a break to recharge mentally for myself in order to go back and do that. And we've had nurses to do that. We've been able to try somehow to get people off here and there in order for them to do that. And they keep coming back. They keep coming back day after day after day after day to take care of our sick patients. And I can't thank our nurses enough, our physicians enough, our respiratory therapists enough for continuing to come back day after day after day to do that. And we as leaders have to continue to promote that, to continue to ask, what else can I do for you? Because you're doing the hard work on the front lines.
Yeah, Carol, I know that you are chair of a department that has a nurse practitioner program that focuses on adults and gerontology, which means some of the people who are most vulnerable during the pandemic, plus a whole variety of other education programs. I imagine that this all resulted in some very creative, but also very challenging pivoting about how do you make sure that the students in these programs are getting the clinical experiences that they need in a way that's safe, and also that they're supported, because as a new nurse, or not, a relatively new person in a field, this is a lot of trauma to experience. What were some of the strategies that you've been undertaking?
Yeah, one of the things that happened with us in an educational institution is we had to change the way that we did things as well, right? Which was transitioning to doing everything remote. And just as Natalie was saying earlier, that doesn't work for everybody. That doesn't work for everybody's learning style. And it hasn't been, it's opened, access to people to continue to be engaged in their graduate programs, or, even as part of the pre-licensure program that we have here at UCSF. But it has been a real challenge because the strain on the systems of healthcare, especially in hospital settings. The other thing that I would bring in, though, and that we do a lot in our department, which is community-based in public health. And for us to think, it's not only nurses that are working in inpatient settings, but there are all these community-based and outpatient settings that are under-resourced. And there's been a real impact on the resources that are available in the community and the public health environment. I think one of the things that COVID has allowed us to see is the lack of resources in our whole public health system. And that relates to nurses too. So even in all of the projects that nurses are doing with public health, maternal child health, a lot of those have diminished because of the need to pull everybody to the COVID response. And so, some of the things that we've done that initially that we did in our department is we had a couple of faculty members, Laura Wagner, and we recalled Barbara Burgle, who is an occupational health nurse practitioner, and they really came in to stand up some of the occupational environmental health services that are going on here and at UCSF as a campus, as well as in helping to stand up what was going on in the medical center, right? And they were very creative in that they found opportunities for our students to be involved in that right away, which was employees' questions. And we have thousands of employees at UCSF, right? I don't know, it's like 15,000 or more, but people calling in with questions or concerns or how to, test and sort. So we transitioned students to those settings right away. And tried to be as creative as we could when we were dealing with institutions who would say, we're so overwhelmed, we can't have students. And so that was a real hardship, right, for our students, of course. But we were able to adapt in those ways. And I think for folks working in the community, as Natalie was saying, and we have programs that are doing primary care and mental health or behavioral health, and a lot of those never shut down, right? Because they're seeing people that would be in psych emergency services or need to be hospitalized when the hospital wasn't able to take people. And so those are some of the ways that our faculty's adapted, and they take the students along. They also worked, in one of the programs that Natalie was talking about, where in Oakland, where in Alameda County, but really in Oakland, where people were housed, homeless people were housed immediately. And our students were very involved in that, doing exams, following people, doing visits to the individuals that were housed in hotels. And so that's another way that our faculty pivoted in the NP programs, and that our students continue to get access to experiences in the community.
Yeah, Natalie, you also referred to some of those same programs that were established. Can you describe some of the advocacy role that the nursing community has played in and also, you know, in addressing some of these challenges and really pushing forward these creative solutions to serve patients in the population more effectively?
Yeah, wow, that's that is a broad question. I think what nursing has done is, and what nursing is really good at, is seeing where the gap is and developing interventions to meet that gap. So in terms of specifics, you know, like Carol was saying, we're having our students go to Operation Safer Ground and really do the temperature checks and talk to people and do assessments. And, you know, not only are they working on their skill sets and interviewing, you know, they're meeting the needs of the population there. I think, like how Pat was saying, you know, he reached out to people who had retired. You know, I'm looking at, hey, it no longer works. We can see that it doesn't work for all populations to go to a visit that they have at 2:00 p.m. and be there on time before the 15-minute cutoff, and they can't be seen anymore. You know, that those things don't work. You know, so how do we build, you know, I always say this health equity, how do we build resources into our systems such that we're able to meet the needs of the community? Because the goal is to have a thriving community and to have optimal health. So you can't split peg in a round hole.
Yeah. Well, you know, and what drew me to begin my own research from an economics background on nursing as a workforce is the recognition that there are 4 times as many nurses as physicians. Nurses are in every setting, they're with every kind of patient in every environment, and their goal is to help people attain the optimal health that they can attain, which is a very different paradigm than any of the other professions, and also means that connection creates an opportunity for advocacy for patients and for thinking both in a one-on-one and in a systems way that you know that you and Carol have been deep in the trenches on, and then of course, Pat, in your leadership role, you've definitely been experiencing that. As you're looking at what people are describing as a current shortage, and boy, it seems like there's a new headline almost every day about the shortage of nurses getting worse because of the pandemic. It's often framed in terms of kind of the economics of supply and demand. And I'm an economist, that's the kind of language that I would use. But are there other ways of describing the shortage that you think might be more helpful, or other nuanced factors that we should be considering beyond just the kind of classic or neoclassical economic models that you know, that don't always seem to apply? What other things should we be thinking about?
Well, you know, it's funny you asked that question, Joanne, because I would say supply and demand is in full force in the nursing field. They continue to raise rates in the agencies because of that. Where the supply is low and the demand is high, capitalism reigns because they are going to ask for more dollars for that nurse who comes to the bedside, right? I just recently had a conversation with a colleague of mine in Kentucky who said that she is struggling just to keep nurses because they are leaving her at the bedside because they can go make 5 times more than what they're making currently by going and traveling. And they know that when they get back, they will be welcomed with open arms in their space to come back. So even if they travel for a year and make a ton more money, 5 times their annual salary than what they're making now, they will then still come back and be welcomed back to do that. So we struggle as chief nursing officers to figure out, how do we retain those nurses, right? How do we retain them to where they're at and what we're doing in order to help them stay to where they're doing? So we have to say, what is it that you need? What is it you need to stay here, either at UCSF, UCI, UC Davis, Kaiser, Sutter? What are we doing to help retain those nurses? Because we know that they're going to get paid more than that when they go out there. What we have to make sure we understand is that you're here in a culture that we support you, that we're here to make sure that we're in this together, so that we're going through this pandemic together, and that you're not at XYZ hospital in Texas, Mississippi, Kentucky, Indiana, Washington State, wherever, that they're seeing you as a body to help them meet a need in order to take care of a series of patients, versus we value as a leader in our organization that is going to help us get through this pandemic to do that. And we will be here for you during and after the pandemic in order to make sure that we're doing things. And we as leaders have to understand that and embrace that we have to make sure that we help our nurses, respiratory therapists, physicians understand that we're here for you. We will do what it takes to take care of you. So for example, because of what you just said around even supply and demand, we took that seriously at UCSF to say, okay, then let's give our nurses some extra shift differential so that we can give them some extra pay if they're going to pick up extra shifts, because we're already knowing they're going out and picking up extra shifts at Kaiser, at Sutter, at Dignity. So why not give them extra pay to stay here at UCSF to do that, right? So we have to think of creative and innovative ways in order to keep them at our organization instead of them finding extra work at other places and then losing them, so that we don't have the staffing that we need here at UCSF. And again, I know I'm speaking UCSF centric, but again, that's what I know, and that's what we're dealing with in the present.
Yeah, so I'm curious, Carol, with your professional networks, as a leader within a nursing school department, what are some of the strategies that you're hearing that academia is able to undertake to have an impact on the current shortage, and also to help kind of prepare to address it, or to make progress towards addressing it? Because it may not be something that can be solved overnight or tomorrow, because certainly the pandemic hasn't been. So what are some of the strategies that you're undertaking or that you're hearing about that we should be looking at?
Well, good question. Good question. I mean, in truth, I would say that the academic environment, it doesn't adapt rapidly. Let's put it that way, unless it has to. And we've done that during this COVID pandemic in terms of changing the way that we're teaching. But I was reading some of the questions in the question and answer chat, and in terms of increasing our number of students, this is where nurses have to be advocates, right? Because the Board of Registered Nursing, which is the state level policies, they manage, or they have direct oversight to the number of students that we can actually enroll in schools of nursing. And this is a state by state sort of a decision. And so it's not like we can just open our doors and say, hey, we'll take this many more students because we have all these applicants, because there are a lot of different system level changes that need to happen. One is with the Board of Registered Nursing on the state level, but the other thing, and one of the struggles that we have is, where are we going to place our students? And we're going to have clinical placements for students, and we're a graduate program, and so our students come in to these programs and they have to get at a minimum 500 of clinical hours, that are patient facing. Some of those things can be addressed through simulation settings, but we need system level change that opens their doors to nursing students, whether or not they're pre-licensure or they're graduate students. And we need big systems, public health departments, hospital systems. We really need that long-term care. I saw Meg Wellhagen's comment in here about long-term care for nursing and nursing homes. And we really need some sort of system level solution to create these opportunities for clinical placements. And, you know, that would allow us to do this in a more efficient manner and for a larger number of people. But that's one of the constraints for us at UCSF of how do we keep enrolling students when we don't have clinical placements for them? And that was really, we really were pressured during COVID when some health systems in our own community, not UCSF Health, but said we can't have nursing students. We can still have medical residents, we can still have medical students, and but we can't place any nursing students. And I think this really points to we need to be louder, and we need to think about some system level solutions to us to demand. If this is a crisis, we need answers. And just what Pat was saying, there's being a lot of money spent on addressing this current crisis. And what about some planning, long-term planning to really shore up some of these systems so we could do this in a way that's going to be meaningful and long lasting?
You know,
Sorry,
Carol,
I got a little excited about that. Sorry.
No, Carol, I could not agree more with you in what you're saying, that clinical placements are needed. One thing that we have to figure out in the nursing profession, so pandemic has caused us to be tired, has caused us to be burnout, has caused us to be struggling with coming to work every day, right? Now you add on, hey, can I give you 5 more nursing students on your unit, right, to have to deal with while you're burnout, tired, and exhausted, right, to do that. What we have to help and turn the paradigm into our nurses on the floors and the wards is to say, this is our future. Without these people coming into our profession and providing these clinical placements, we are not going to have these nurses who are going to back us up. So when X nurse retires next year, who's going to replace you? We need to have that nurse who's coming through the pipeline to replacement. And if I'm not giving and passing down my clinical knowledge to that next nurse, what am I going to do? We need to help our nurses understand that they're leaving a legacy by providing those nurses a preceptorship on those units so that they can provide that extra care, that extra help, the extra knowledge that they're passing down to the people who will be taking our places in the next coming years.
Yeah, I would like to jump in here too as well. One, to plug for precepting, if you're out there, we need preceptors. And 2, the economics, I don't think people get the impact of COVID for the future. Okay, so these people that have been living with or have lived through COVID have damage to their lungs. Their vessels have been slightly damaged or altered, and there is something possibly going on with their immune system as well. So, and possibly due to COVID, they had little micro like things going on in their brain that they had lack of oxygen. Okay, little ischemic attacks. So there's going to be some cognitive issues in the future. And I'm going to tell you this, your nurse practitioners and your nurses are going to be the ones dealing with this. So the state needs to definitely give more investment in nursing for the future, and understand that in 5 to 10 years time, there's going to be new training. Even me as an infectious disease specialist, I'm realizing I'm going to need some training. Well, I'll probably be doing more research by then, but I'm going to need a lot of training to train nurse practitioners on how to deal with people who have had COVID. So, and the bills that people are going to have to pay, the hospital bills from those long extended stays, are going to have an economic impact on the back end as well and shift the economy. So I want people to realize that we've got to really think about long-term resources in terms of nursing as well.
That's a great point. And there are a few comments and questions around what I'll describe as the underlying economics of the precepting and engagement of faculty. it's, you know, there have long been concerns about faculty shortages. The faculty workforce on average is older than the nursing workforce, and faculty salaries are historically lower by a fair margin than what people can earn in a clinical setting. So what are some of the strategies that you see to try to address some of these problems? And, you know, to what extent do we need to worry about this constricting our pipeline of nurses into the future?
I think it's a big worry. I mean, for me, from where I sit, I think it's a big worry. I mean, I'm looking at all these things people are asking in the chat, and I mean, it is a big concern that even our faculty and the preceptors that we've had long relationships are being approached by different organizations and being offered money to do precepting in place of the precepting they're doing for us and even our faculty. And so one of the, you know, it's like money in healthcare. You know, I don't know how we can separate the two. You know, it doesn't seem possible. But it's hard when money is the driver. I mean, here at UCSF, one of the things that this is a conversation I have with a lot of faculty is around the pay rate. I mean, the pay is not as good for faculty as it is for clinicians, right? And one of my mantras is, you know, public education is undervalued in our society. And UCSF is a public institution. It's just undervalued. And so how do we increase the value? I mean, it's an exciting environment, and it's a challenge. I mean, it's a challenge for us. I think that our Associate Dean of Clinical Affairs Gina Schuler, is really working with our faculty and what we term as our volunteer faculty, and a lot of those are preceptors. But how do we really support that group of faculty who are, you know, doing this work for us that we can't survive without? And what do we do for them in return? And we do try to engage with our faculty that have volunteer appointments and offer different resources, whether or not it's access to all the library facilities or, you know, just the opportunity to teach and fill a different need that they may have than the one that they're, you know, addressing with their clinical work. But this is a big problem, right? And this is one of the things that I think not pressuring the individual to, you know, onboard a new clinical site where there's a lot of work for a new preceptor, but how can we create a system that makes it easier for people to do this and to show value for these individuals? And that's something we're really engaged in at UCSF in the School of Nursing. So that's what I would say about it, but it's a really big challenge and it just becomes bigger and bigger, right?
Yeah, so I want to turn the similar question to Pat, because there are a number of questions specifically around preceptors. And, you know, it's extra work for somebody, even if they're not formally precepting a student, to have student nurses running around the floors, right? So what are some of the strategies that health systems can undertake to really help support the educational mission, which is absolutely essential to your having the future workforce you need?
It's a spot on question, Joanne. And, you know, one of the things that we're challenged with, and Carol said it earlier, right? It's not about financials, but it's all about financial, right? And so are we providing enough incentive to our nurses to take on preceptors, to take them? And as difficult as that is to say and to do, it is reality that unless you incentivize certain individuals, they will not take precepting students on to do that. There are many who do that because it's in their inner being that they want to educate the next generation, right? They want to do that. And if you add incentives on to that, there are other people who will step up and say, I'll take a student, I'll take a student. If you're going to pay me $100 every student, $200, $500 every student that I take on a precept for 6, 8, 12 weeks, I will gladly do that. So where were they before when I didn't offer an incentive is the question, right? We all struggle that with as chief nurses to say, what is the right approach to do? Because throwing money at everything is not the answer. And it can be the answer on occasion, because if you're not getting enough clinical spots and people to precept students, that's what you have to do in order to get people through the system. So it's that balancing game that we weigh as chief nurses to say, what are we going to do going forward for the future?
You know, my idea on this for preceptors is I loved precepting. I had amazing preceptors, and I think this is a pay it forward thing. Like, I mean, it's slightly judgmental, but to be paid for it, I got paid in the beginning, and the fact that I come to work every day and I'm a great nurse practitioner, that's like my payment. So being able to have a new student and say, follow me, we got a large schedule. Like that used to juice me back in the day. And people got to my students got to learn, and they got good, and they could manage a panel when they graduated. So, I think it may be like rethinking like how you precept or how you view precepting. Because there's been precepting since the beginning of nursing. So why is it all of a sudden now an issue and needing a financial attachment? And this may be related to some of the system issues of RVUs and nurse practitioners having to maintain a certain level of RVUs. And that could actually be some of the payment that, or financial support that could be giving to especially nurse practitioners or nurses as they precept.
That's a great point. Now, so there's been some questions around around some of the educational trajectories with more nurses being interested, or at least anecdotally being interested in pursuing advanced certifications and pursuing advanced practice nursing in general. What are some of the opportunities to help facilitate that career development for nurses, whether it's a formal degree, right? There's some amount of like, oh, I need to get a master's degree. What are some other ways, in addition to the graduate education, that we can facilitate professional growth for nurses, which I think there's a lot of data that tells us that is a really good way to help retain people in an organization, is for them to feel like they have growth opportunities. What are you seeing, Pat, in terms of strategies that have been successful for you in addressing this, improving retention through career growth? And then I'd be interested in your thoughts as well, Carol and Natalie, with what you're seeing on the ground in the education side.
Yeah, I would say we start by, again, offering certification opportunities and helping pay for those certifications. That's number one. People who want to go into leadership, formal leadership roles, we constantly promote that and ask people to go into those areas. Our nurses have the ability to become CN3s and CN4s, which helps them to go into future advancement roles, to use their expertise on their units in a better way, in a different way, in a holistic way that helps our patients and helps our staff become better in those spaces. I have to interview all of the new CN3s that are coming through before they get their CN3 or CN4 promotion. And I can tell you the projects they have to deal with and the projects that they go through for the year that they have to do that are amazing. They are amazing. And you're right, Joanne, it helps retain them because they see that their value add as an RN in our organization can really make a difference. Every single interview I've been to, every single one of them has made a difference in their area. And when they become CN3 or a CN4, they're seen as the expert in their space. And people go to them because of that in those areas. So lots of things. And again, we promote education. We promote them going back to school. We make them a priority when they want to go back to school. It doesn't always happen. I can just guarantee you it doesn't always happen that we can give them reduced percentages, but we try as much as possible to do that, to promote their growth and give them advancement in the organization.
I mean, the other thing that I was going to say, and I know I'm like getting distracted by all the questions and the question that you asked, Joanne, and what you said, Pat, but I also wanted to say in the School of Nursing, we also now have I think it's a leadership institute it's called, that has the possibility for certification in nursing leadership areas, as well as, opportunities to come back to school, whether or not it's part-time or full-time. And some organizations like UCSF that will help assist with tuition. So one of the things, we do have those opportunities, and they're available in different, places, depending on what you're looking for. If you're looking for an advancement for your education, changing your field, where you're working, or, just to increase your skills in something, there's a lot of reasons, right? Or people want to go into advanced practice nursing. One of the things that I did want to respond to over that somebody asked, and now I've lost the question about, but I think it was about institutional culture and burnout. So I just want to address that before we end, because I think that was something that we wanted to bring up. And one of the things that is a value of advanced education and is important for all of us as nurses is to remember part of our roles. For me, I always think of nursing as a social justice profession. And we have something sort of beyond us that we're concerned about, the health of the population or the health of our communities. And we do go into nursing usually for a reason that we want to do something more, make a difference, take care of people. And for some of us, it's a good profession. It's a good, solid profession where you can make a good income, right? And it provides you opportunities. But I think it's so important for us to keep involved in nursing, advanced education, and leadership, because we have to change the system that doesn't allow things like lateral violence from others that are working with us as nurses or in the patient care setting, and can really change our policies at the institutional level that will address the needs of nurses around the burnout or toxic work environments. And I know Pat and I have worked on a couple of these initiatives, and really involving the current nurse leaders and nurses who are moving into leadership or learning about it. How do we change policy at the institution level, at the nursing unit level, at the state level, at the federal level, that recognizes this and changes, the way that things run. And also that saying, we want to be more focused on, compassion might be an overrated word, but we are in there, and we are not only doing physical labor, ma'am, we are doing emotional labor, and it wears you out. And we need to, that's something that's so important and valuable. Everybody knows it. And that's one of the things I was saying in the beginning of the epidemic. People really saw what nurses were doing, and they talked about it a lot, about the value, and it's so valuable, and all these stories. And we need to be involved in having our voice be heard about this, and then creating change that's not just at the individual level, but really, acknowledging the importance of it, the importance of the work, and having that be changing our work setting so they're more caring, if you will.
Well, so
I wanted to piggyback on what Carol was saying, just about just thinking about when I see nurses, or when I saw nurses through the pandemic and losing people, and we weren't created for that. We were created to heal, and lives were slipping through people's fingers on a daily basis, like hourly in some places. And that does create the human being has to create some way to survive through that. And that creates also a fatigue, a burnout, a hardening, or an apathy, which could lead to some depression. And I think that one of the things we've got to think about is the self-care. I saw someone Catherine Dodd is posting about healing circles. I think meditation, I've been training people with meditation and mindfulness, but we've got to think of innovative ways to create is within the institution where people can go and recharge in the middle of the day of quietness.
Natalie, I love that. I was involved in an integrative nursing approach at UCI when I was down there. And we need to create something similar here at UCSF just to do exactly what you're saying. I had a nurse approach me the other day and said, Pat, thank you for what you're doing now, but I don't want you to forget me a year from now, 3 years from now, and 5 years from now, because PTSD is real and I am going to have long lasting effects from this that I may need help from you 5 years from now. And Natalie, that was just to what you were just going on, was just a slam in my face to say, we need to pay attention to this over and over and over and over.
It's a war. It's been a war.
So I want to think about that long term, Pat, since you brought that up, and the kind of the resilience and the things that draw people to nursing, apart from it being a fascinating job where you can have all kinds of clinical, technical challenges and so on, that it's also a job where there's a lot of personal connection. So when we're looking at bringing new people into our nursing schools, like the very entry level of nursing workforce, we saw huge growth in nursing programs in California and nationally over the kind of 2001 to 2008 period of time. And thankfully, we've been able to hold up those numbers and even continue to grow our educational programs statewide to help ensure that we have enough nurses. So how do we keep building on that success? And I think also importantly, build on that success in a way that continues to increase the diversity of our workforce so that our nurses continue to better and better represent the patients that they're serving. Thoughts about that as the big picture is for the future of dealing with any shortages that might be emerging.
So I'll start and ask my colleagues to add on. I think, to that, we, one of the things we have to do is continue to reinforce that new grad nurse residency programs at all of our hospitals across not only California, but across the nation are so imperative, and that we have to put strong processes in place to do that. We have to convince our CFOs and CEOs that they are needed at our organizations, that they are not just a nice to have, but they are a must have in order to decrease the nursing shortage across the United States. We do have lots, to your point, Joanne, lots of nurses coming in. There are more applications for nursing schools than there are spots. But if we don't bring those nursing students into the fold quickly, get them the experience they need through the preceptorships, and get them in hired quickly thereafter, they're going to go do other things, and we're going to lose them in the inpatient space. So I'll stop there, knowing that we have short time, and ask my colleagues to add on.
Yep. Any final thoughts from Carol or Natalie regarding bringing, more students into the pipeline while we have about 1 minute left?
I'm looking at HBCUs.
Right.
Just because
Right.
I went to a HBCU. So one of my goals is to institute a pipeline from my institutions of Spelman and Morehouse and possibly other HBCUs. So that's me.
Well, and Natalie, to that point, I went to an HBCU as well. I'm a Florida A&M grad, just as a FYI. But to that point, we have to start hiring more ADNs, right? Many magnet organizations have gone away from that to increase their BSN percentage because we had to, but we didn't see the forest before the trees. And so literature supports that ADNs programs have a more diverse a field of nurses in there. And so we have to look at our ADN programs and bring them into the fold. And again, promote them to go back and get their BSN or their MSN or their DNP or their PhD, right? But to bring them in so we can have a more diverse workforce.
Yeah. And we need to change, we need to advocate at the Board of Registered Nursing at the state to allow us to increase the number of nursing students we can have. That's another approach. So.
Well, that is a great note to end on. I think we could go on for another hour, but we were told we had 1 hour, and we really appreciate all the fabulous questions that have come in. I think that I think our panelists might still be trying to type responses to some of these before everybody fully shuts down, but it is time for us to officially end our program for this evening. All of us are pretty easy to find on email through the UCSF profile system, and to ask questions directly. Thank you, Natalie, Carol, and Pat, for also educating me. I'm kind of the nerdy researcher, and I learn a lot from you because of your experiences and the passion of the work that you do. So thank you, everybody, for coming tonight.
Thank you all.